continue with more insights. It gets a little bit more concrete with Alfredo Mirandola from CNAO in Pavia, who will tell about the treatment planning process for pediatric cancer tumor.
The one or the arrows?
Which one?
This one or the arrows? What do you want? The arrows.
Okay.
I can put them later.
Okay. Thank you very much to organize the invitation. Today I've been asked to talk about pediatric treatment planning, let's say. So this is my summary briefly. So at the beginning, the advantage of protons over the conventional radiotherapy, then planning with protons, and then specifically planning children's with protons. So I don't want to bore you about the inverse dose distribution of the proton or ion in general, but just to say that we can have a very nice target coverage, even in terms of DDH or homogeneity index or conformity index with the protons using few beam entrants. Sorry. That's very important, especially for children, because we have to spare the normal tissue. So if we can reach the same dose distribution to the target with few beam entrants, this is the best option, of course. I want to show you some clinical cases really treated at CNAO, starting from the simplest case from the medical physicist point of view. So the vesicular irradiation, for example, because there is a big tumor in a very homogeneous zone, the cranial district is very homogeneous. So even in this, let's say, coarse target, the advantage of protons is evident, because if I show you the plan with the fixed beam line, even the fixed beam line give the nice result. In fact, we have the lower mean dose to the healthy brain than VMAT, lower mean dose to the temporal lobes than VMAT, and similar, even better CTV coverage than VMAT. The same exercise can be performed with the gantry, so no particular difference are seen in this case for gantry or fixed beam line with protons. So even for this simple case, protons show a clear advantage. But this is not the most elective case, let's say. Just to show you something else, this is a schwannoma. So the upper part, there is a proton plan. The lower part, there is a photon plan. Behind the DVH, they are quite similar in terms of coverage, because the red DVH of the red structure is the CTV, and it is well covered in both technique. The pink structure is the spinal cord, and more or less for those higher than 50 gray, the DVH are the same. But as you can see in this part of the graph, all this anterior part of the patient is completely spared with protons. So all the oral cavity, teeth, lips, pharynx are completely spared. So this is a clear case of proton better than photons. Again, a lymphoma patient, the dose is 20 grays, around 20 gray, and it can be well covered with one beam only too. Respect to photon, the difference is clear in terms of those sparing to the lungs, the spinal cord, to the heart, to the breast, and this is reported in this paper that we published a couple of years ago. Again, this image you've seen many times, the cranospinal radiation. If you look at the anterior part of the patient body, there is dose coming from photons. Here there is nothing, or almost nothing coming from protons, and this is clearly reported in this paper that show the clear advantage of protons. Again, neuroblastoma. This is our publication of I guess the first months of this year. in which we can see the enormous sparing for kidneys, for example, in this case, but in general, we have the sparing of kidneys, of spleen, of bowel, of every district using protons. These are all these pictures come from real patients. But they are not only pictures, not only colors. If you spare the organs, the normal tissue, you help the quality of life of the patient, and this is well reported in this, for example, in this paper regarding the brain complications of the treatments. Same for secondary cancers. There's still many publications because the scientific community wants to see results on a big cohort of patients, and this is a very big cohort of patients from the US in showing the lower probability of secondary cancer with protons. But protons, yes, are nice, but we have to. I want to show you some difficulties in managing the protons. Not to say that is the paradise, but just to say it's something that we have to know how to manage, because there are sort of uncertainty more than photons in terms of measurements when you're commissioning a new machine. These are physical source of uncertainties, energy constancy, momentum spread. But there are uncertainty due to the patient in the treatment plan. For example, the organ motion of the patient, the anatomical change that the patients can have. It's quite difficult to manage the metal implants, the artifacts, and last but not least, the biology. The RB is relative biological effectiveness. It's said to be 1.1 everywhere in the spread per pic, but it's not completely true. The previous slide showed the general aspects of the source of uncertainty for protons. These are okay. This slide is more specific for the pediatrics because what we have to know about this is that we have small volumes, both in terms of targets and organ risk in general. The patient grows during the treatment course, can pass 1 month from the simulation to the start of the course. The patient can grow, because if we have a 10-month-old patient, 1 month means 10% of his life. We can face the higher sensitivity respect to others for specific disease, and we have to take care of the comfort and the compliance of the patient because they are very, very, very young. So we have to be robust and fast when we deliver the plan, because these patients many times are under anesthesia. So we need few beams, very robust, and for the biological point of view, we have to take care of the LET, linear energy transfer optimization. This was I was talking about. These are the dimension of some disease we have to treat. So 2.5 millimeters, 6 millimeters. And if for others we have the spot spacing of our pencil beam at CNAO is about 3-5 millimeter, both in X and Y direction, with the minimum number of particles per spot, 1.6 10 to 1.5 10 to 6 proton per spot. If we want higher modulation to be more precise and more accurate and more homogeneous to the target, we could go down to 1 millimeter spot spacing and lower minimum number of particles. So we have to change the settings of the TPS sometimes for treating children. Again, the single field uniform dose, this definition from Tony Lomax, the combination of individually optimized field, each of which deliver a more homogeneous dose across the volume, is an option that I personally use for the planning with pediatrics, because it's more robust than IMPT. So it's not something that we have to completely forget, the single field uniform dose. This is an example for cranopharyngioma, 3 three beams, two horizontal and one from the vertex, in single field uniform dose. Again, small change led to big impacts. This is an example of neuroblastoma. If you have a look here, the target is well covered. During a revaluation CT, we have this situation. So the target is fills and move displace completely the target. So here we have target missing. So we have to replan for this. We have to replan for this case, and we planned a lot for. This is our experience in CNAO 6 months. We have 40% of the replanning for pediatrics. Last argument is the RBE. So the RBE is in the treatment planning system is homogeneous 1.1, but this is not true because it is dependent on the LET. So at the distal part of this range, the LET is higher and RBE is higher. So what we have to avoid is to put all the beams with the distal edge to a very important organ risk. For example, the brainstem in this case. So this is something to be avoid if possible, but not always is possible. For example, this is a 18 months old patient that we are treating these days at CNAO, in which, as I told you, this part, this square here, is untouchable from the beam because it's we have completely spare. So we are limited to this part, this hemisphere. So I used two beams, and both are were going to the brainstem. I depict this red one is a high risk area for the LET because it's not a clinical structure, but it's a physical, let's say, structure, and this is inside the brainstem. So we have to manage this part. And what they did is, if we have two options, this is the upper part is the LET optimized plan. So trying to have to put lower LET in this zone. This is the standard plan. Both plans here show a similar, maybe the same DVH for CTV, and for the gray color here is the superimposition between brainstem and CTV. And we have the same DVH at the high dose for the brainstem. So these are two plans are acceptable, both acceptable for clinicians. But what I show the clinician is the LET optimized, because with the same DVH, the same dose distribution, we can improve the LET distribution. This is the case. So in this red zone, what I did spare a little bit in terms of LET. Many times, for a particular case, this is the case, we recalculate the RBE plans, fixed RBE plans to other models, other biological models, to show what could happen to the organ at risk, and this was the case. The last few words about what the community, European community, is doing for treating pediatric posterior fossa. So these are two cases, ependymoma and ATRT, sent to 16 centers participating in this survey. If you look at the DVH, more or less, we are homogeneous. So the red one is the mean, and the other is the 20 to 40 percentiles, etc. But the way to optimize this plan is very difficult. There are three out of 16 facilities that are still optimizing with the planning tumor volume. This is something that we have to delete. The rest are planning with the CTV in a robust way. But the most important thing is that someone used 2 beams, someone used 3 beams, someone else 4 beams with different angulation, and it is something that has to be standardized. Last slide. What's next? We can use proton therapy for children. I don't know. New ions, maybe helium can be. And what about the multi-ion radiotherapy? So for proton therapy is the standard for particle, but as Aristotle said, even when laws have been written down, they ought not always to remain unaltered. Thank you.
Thank you very much for giving us this insight into the treatment planning for pediatrics. Any comments from the audience or online?
A question, we have shown a lot of comparisons, protons and photons. How this was done is data that you analyze afterwards, or you say you go for protons, you go for photons, and they compare?
50-50. Sometimes the clinicians ask me, can you show me the some centers sent to us some plan with photons and tell us, please let me see what would happen with protons, and I do the plan and we see the difference, and then they decide which particle, usually proton wins.
Yes, can I have a question? Yes, sorry if I didn't catch it, but when you have a clinical plan where there's a sensitive organ at the distal edge where there's the high LET, what's the solution? Do you replan, you change the angle, or?
The solution now, since 6 months, we have the LET optimization module in our TPS, so we're using it. In the last year, two years ago, I changed the angulation. I tried not to place the break peak in next to the dead zone. Sometimes I used contralateral beams, but it's not the case for pediatrics. So now you can use the LET optimization. That's the best solution.
Okay, and is that always possible, even like in terms of robustness, depending on where the location is?
This is a good point. There is the robustness in terms of dose, we can do it. But if you are talking about robustness in terms of LET, at the moment the software doesn't help us. This is a good point.
It's definitely a very interesting topic. LET is something we have to deal with carbons on a daily basis. For protons, I would say we are just starting, but this probably goes beyond what we are able to discuss here between the talks. So maybe I can just invite to discuss this later on also in the coffee break, because it's really a very intriguing topic. Thank you again. Thank you very much.
Thank you.
Just one more minute, please.
Yeah, here closes the session in this room, but I just wanted to remind you that in the main auditorium, Professor Roberto Orecchia and Arnold Campos are giving a presentation in the framework of the Aristotle Medical Forum in the session of the role of artificial intelligence in radiation therapy. So I encourage you to just step in the main auditorium. Thank you very much.